Hello and welcome to this VetLit podcast. My name is Simon Cook. I'm a criticalist here in the UK, and today we're tackling peri-operative antimicrobials and when not to give them. Very recently, there were some guidelines released on surgical antimicrobial prophylaxis, and there were some very clear recommendations inside them with the potential to have a lot of impact. And we have Fergus Allerton here to discuss them as the lead author amongst a huge panel of representatives. You may remember Fergus from such initiatives as SAMSOC, so the Small Animal Medicine Society here in the UK, the Protect Me guidelines on a wall in a practice near you, the Stop on Sunday Antimicrobial Treatment of UTIs initiative, the Antibiotic Amnesty, and the list goes on. Fergus, hi.
Hi, nice to see you, Simon.
Thank you for joining us. I might start with what problem were you collectively trying to solve with these ENOVAT guidelines? And maybe you could include a brief intro to ENOVAT itself. So that's the European Network for Optimization of Veterinary Antimicrobial Therapy, with whom you've or under whom you've created these guidelines.
Yeah, well, the ENOVAT initiative started in 2019, and collectively we decided to tackle a few different areas across species. So there were guidelines generated for bovine respiratory disease, for poultry coli bacillosis. But on the small animal side, we looked at canine acute diarrhea. Those guidelines were published in 2024. And surgical antimicrobial prophylaxis. The main motivation for that was recognizing this is sort of the only reason we give otherwise healthy animals antibiotics.
Mhm.
And it accounts for about 15% of all antibiotic use in small animals and in people, interestingly, similar numbers. And we want to make sure that that is appropriate use. About 50% of it probably isn't. So if we can cut that down, we could make big headway in the total amount of antibiotics being used.
So you estimate that about 50% of the current perioperative antimicrobials can be gotten rid of?
Pretty much, yeah.
Yeah.
And I think there's lots of opportunities to improve the way we use them.
Okay, cool. And then tell me a little bit more about ENOVAT itself.
So ENOVAT is now complete. It was a cost action from the European Union. It lasted for about 6 years, and we did generate some really good guidelines, as well as a lot of other deliverables that you can find on the ENOVAT websites. But since that funding has now ceased, a new phoenix has risen from the ashes, and that is the International Veterinary Evidence-Based Guidelines Group, based out of the University of Copenhagen. And what we hope is that those ENOVAT guidelines across the board can be maintained, and the IVEG will provide support for any group that wants to generate evidence-based guidelines. So if you're thinking, well, that topic, I'd like to know how to do that right, ENOVAT, or IVEG now,
Yeah.
will provide the methodological support to make sure that guidelines are generated in a robust way, using things like grade methodology to review the available evidence, systematic review, meta-analysis, and generate recommendations that we can feel confident on when we're applying them in practice.
Brilliant. Okay. Excellent resource. So then you've got in these guidelines, you've got a number of very specific situations in which antimicrobials were specifically advised against, and I'm going to go through some of them just here, and maybe you might throw in a couple of comments here and there. So let's start with neutering. So no justification for peri or post-operative antibiotics, full stop. Are there any caveats, or tell me?
Well, I hope not, but it's been probably 20 years, no, 15 years since I was allowed to operate on an animal. And I guess if I was suddenly made to operate on an overweight Labrador and perform a spay tomorrow, I could anticipate that might take me a while. And if we expect that any procedure is going to last longer than 90 minutes,
Yeah, yeah, yeah.
then there is a separate reason that we might consider antibiotics. So you do have to make allowances for any particular procedure. You may feel that a particular animal has various comorbidities that mean it's more fragile. It may be a higher ASA class, for example, and those things can warrant individual consideration of antibiotics. So these guidelines are designed to be broad, but we still rely on the clinician making those individual decisions. And with the spay in particular, or the neutering recommendation, we did base this all on working in the UK, working in Europe, working in the US, where facilities are good and you're working hopefully in sterile theatres, wearing sterile gloves, doing things in a controlled environment. But that may not be where the majority of spays around the world occur. And those facilities aren't ubiquitous. If you're working in a shelter or a neuter clinic in a low resource setting, then the level of sterility and surgical asepsis may be compromised. Now, my view is that probably even in those settings, the need for antibiotics, peri or post-operatively, remains very low. But we haven't got the evidence to make that statement yet. Yeah. And that's something we're looking to address. So we are trying to set up some randomized control trials, working with institutions and charities who are in those fields to see if we can provide the support, the actual proof that antibiotics don't make that difference, don't reduce those surgical site infections in a way that warrant their routine use.
Excellent. Okay, so clean procedures. So your splenectomies, your dermal rasp removals, etc. No justification of peri or post-operative antimicrobials in those settings.
Absolutely. There's some great work from the University of Zurich looking at splenectomies in particular, which showed very, very low surgical site infection rates without any antibiotics. So I think we can be confident in that scenario that these are unnecessary and they're not going to make a significant impact, and we can manage very comfortably without those.
Brilliant. Yeah, and I suppose that that does even cater for both types of splenectomies, the routines or the emergents, with the 90-minute caveat, but feasibly that's not breached in many situations. But as you say, all situations, all cases are very different, aren't they? Clean, contaminated urological procedures. So you enter a bladder electively. There's no evidence of infection. No antibiotics, peri or post-operatively.
Yeah, absolutely. So I have to say that among these recommendations, we have different strengths of that recommendation. So this is based on weighing up the available evidence. How confident are we with these recommendations and the anticipated harms? And I think we should address that fact that if we keep using antibiotics in the way that we are, there is a risk that multi-drug resistant infections will become more common. Antimicrobial resistance could compromise the level of care that we can afford our patients. So we might not be able to offer chemotherapy if they all develop multi-drug resistant infections. We may not be able to perform some of these complicated surgical procedures, these implant knee replacements or hip replacement surgeries that we're doing, if we are exposed to high rates of multi-drug resistant infections. So we felt confident that if you overuse antibiotics, there is a harm. But we didn't always have that strength of evidence to make a strong recommendation. So the one you've just given, the cystotomy example, it is a conditional recommendation, i.e. we feel that it is, in the majority of cases, it is appropriate to not use antibiotics. But we, again, rely on the clinician to make that assessment. What is the state of that bladder? And you need to make that assessment before you go in. It's not like you get in there and you say, oh, crikey, this is a little bit more messy than I expected. Now I give antibiotics. That's not going to have that desired effect. You still need to do it in the right way. But if you have concerns about how well that patient is, the integrity of the bladder wall, possibility of underlying infection and things like that, then that might lead you to use antibiotics. Okay. But overall, we felt, again, no antibiotics required in that circumstance.
Brilliant. Okay. There are some more sort of contentious is the wrong word, but exciting points to discuss coming up. So, um, clean contaminated gastrointestinal surgery. So you enter the GI tract electively. There's no spillage to speak of. We're going to say justify the peri-operative use, but not the post-operative use.
Yeah, and again, I would say that the gastrointestinal tract can't be considered as a single thing. So if you are going in to remove a golf ball from the stomach, then we said no antibiotics. Gastric surgery, no antibiotics required. And we had some discordance in the group over how we should approach enterotomies or enterectomies.
Yeah.
And we had some forthright surgeons who said, look, we're managing these procedures. We're not seeing significant rates of surgical site infections if we use no peri or post-operative antibiotics.
Yeah.
But the consensus was that probably there is a risk of contamination, and therefore we made a conditional, which is a suggestion really, to use peri-operative antibiotics for GI surgery or intestinal surgery.
Yeah.
And we've seen no reason to continue that beyond the 24-hour period. That's the definition of peri-op, is 30 to 60 minutes before your procedure, right up to maximum of 24 hours post-procedure.
Yeah,
so
okay.
If you've had a very long procedure, you might have had a couple of interoperative dosings, or you might feel later on that day, I'm going to give an extra injection. That still counts in that peri-operative window. Anything that they're going home with, the 24 hours and beyond, that's your post-op. And that's the one that I really want to try and discourage as much as possible across the board.
So how much can we discourage them in the next category? So in the contaminated soft tissue surgical procedures. So you've got gastrointestinal tract leakage. We're all happy with the principle of them having perioperative antibiotics, and then maybe or probably or somewhere on this spectrum, there's a case for 3 to 5 days of antimicrobials, as you suggest. Where do you stand on that? And maybe I'll ask you now. Is this one you think that we might be able to make more progress on over time?
I hope so. And again, we didn't have the evidence to answer this question confidently. We tried to infer a little bit from human guidelines and their approach. And probably 3 to 5 days is excessive by those standards. Often in human medicine, it's going to be 1 to 3 days maximum. I'm a bit of a pedant for terminology, and you could argue that if you're treating a contaminated procedure, you're actually recognizing the presence of infection. And therefore, is it truly prophylactic use, or is that more therapeutic use?
Okay.
And therefore, is it acceptable to say, look, I have had a compromise, a breach to the surgical asepsis, or maybe it was a procedure into a polypoid cystitis, horribly septic, effectively bladder, then yes, I think you can make a case for a few days antibiotics. But you're probably right, and I hope you are right, that if we can get more evidence, we can start bringing those recommendations down. We can reduce the amount of time that those procedures require antibiotics. And we're learning, and there's some brilliant research coming out of the RVC looking at how long you should continue antibiotics post-septic peritonitis. And you'll note that no dirty procedures are included in this work, but we can learn from that. If you're not using weeks and weeks of antibiotics after that type of procedure, why would we use it after a contaminated or lower tier surgical procedure? So these are the things, that indirect evidence that we need to feed off.
Yeah, that's the one that I've got a vested interest in those post-op septic peritonitis cases. There's a huge spectrum of course lengths that people are prescribing post dose, literally ranging from 2 or 3 days, even up to a couple of weeks and more. So yeah, I think there's a huge amount of scope to make some progress there, isn't there?
There is, and I think if we can see that is we can manage with those shorter courses, and I'm confident we can, then hopefully people will build that confidence and start questioning why they're using that post-op in any context. And for me, that remains the big win. If I could make one big change with these recommendations, it is to reduce, hopefully virtually eliminate post-operative surgical antimicrobial prophylaxis. That's the big win.
Cool. That is a really cool aim. I'm jealous of your ability to deliver that with these guidelines. It's awesome. Okay. And then the other one I've got noted down was things like elective BOAS procedures. They were almost in a separate class, but no peri or post-operative antimicrobial was justified in that kind of soft tissue procedure.
Absolutely.
So then you delve also into orthopedic procedures, including TPLOs. Now, I'll be honest, and Fergus is wincing as well, but these are very far from my bread and butter. But no antibiotics in non-implant orthopedic procedures, and then only peri-operative, not post-operative, where implants themselves are used. To try and summarize those briefly.
Yeah, that's absolutely right. We did make a special category for TPLOs simply because there's so much more evidence.
Yeah.
I think that's it's a lovely quick project, isn't it? You've got quite a good retrospective database that you can work on TPLOs. So people have done quite a good amount of work. And so we were able to make a specific recommendation for TPLOs. And we feel that, yes, peri-operative antibiotics does make a difference. And that could be 1 or maybe 2 injections of peri-operative cefuroxime, cefazolin, and no need for anything further. So we don't feel that post-op antibiotics were necessary. And I'd love to mention Mark Morton's brilliant RCVS knowledge, Cruciate Registry.
Yes.
So you can, all vets in the UK can feed into that. Brilliant resource, and excitingly, already his data suggests that I think it's something like 2/3 of vets don't use post-op antibiotics for their TPLOs. So we're making progress. It's going in the right direction. Let's build confidence and copy our peers on this, and we can rein back that tendency to say, here's a week's worth of unnecessary safety blanket so that I feel more confident that my operation's not going to go horribly wrong.
Excellent.
Yeah.
I'll make sure there's a link to that specifically, because that's really awesome to read as well. A couple of final questions, and this fits quite well with that previous comment of yours. Implementation is presumably the harder part. How do you monitor the response, if there is a direct one, to these guidelines? Who else or who is tracking this kind of usage?
This is going to be something that really does change in the next few years. We may start diverging from our European colleagues, embarrassingly, on this one. So within the EU, there are requirements to record all antibiotic use in cats and dogs by 2030. So they will have good metrics on some of these, and you can work out what most antibiotics are being given for. Cefazolin, which is the go-to peri-op antibiotic, is for surgical antimicrobial prophylaxis nearly exclusively. So you could monitor that particular antibiotic. You could see how frequently it's being used, and you could get an indication of surgical antimicrobial prophylaxis. So they will have better data in the EU. I hope that the UK will follow that, and I know that the VMD are looking at ways to encourage groups to get good metrics on your antibiotic use. I think that we should incorporate targets, and through Wasava and ISCAID, we did generate a separate target document. And what that's saying is by 2030, we want a maximum of 5% of procedures to have post-operative antibiotics. And that's recognizing that there is going to be the odd one, the odd thing that catches us out. So we didn't want to be too stringent. We
Literal.
wanted to
Yeah,
give
yeah.
a little bit of wriggle room. But if we can cut it down to 95% of procedures, no post-op, that would be brilliant. And certainly 95% of clean contaminated procedures also we feel should not have peri-operative antibiotics. So those are the targets. They are what we're working towards, and we would love it if practices could start trying to work out where they're at on that spectrum. How frequently do we give antibiotics? How frequently do animals go home with antibiotics after a surgical procedure? And how can we improve? How can we work towards reaching those sort of thresholds?
There's some really cool potential for internal audits there, isn't there?
Absolutely. And RCVS Knowledge Antibiotic Guardian Awards, which are done yearly, encourage people to perform those type of audits. This would be a lovely topic for that type of audit. Where are we at the moment? Let's have a look at the guidelines. Let's discuss it as a practice. Let's encourage each other not to use antibiotics in this context, and let's see where we are in a year's time. And if you did that before and after, I think that would be a very, very strong candidature for an RCVS Knowledge Antibiotic Guardian Award.
Very cool. Very cool. And also exposure to ultimately formal research.
Yes, indeed.
One question just to wrap up then. Fergus, are you allowed to give me an update on any of your other ongoing studies or ventures? Because it seems like tracking your activity is very much like looking into the future. So can you spill the beans on anything?
Well, there's loads of things that I think are interesting, and I've got one that I'm really keen to try and understand, and that's looking at the use of amoxiclav. So I think amoxiclav is a great antibiotic. It's the most commonly used antibiotic in Europe, and if you want to use it for a non-urinary tract infection, which quite reasonably, it's on the Protect Me guidelines, we feel it's a good option for managing cholangitis or cholecystitis. But the updated CLSI breakpoints, these are the people who define what determines if if a bacteria is likely to be resistant to a particular antibiotic, they now suggest that all non-urinary Enterobacterales, that's your E. coli in particular, all non-urinary E. coli infections will be resistant to amoxiclav. That is their current statement. That's the breakpoints as they stand at the moment would mean that you should not use amoxiclav for that. And remember, your lab reports it. They have to decide whether they apply the CLSI breakpoints, whether they use UCAST or they use breakpoints from pre-2013. And if they state that something's resistant, chances are quite a few of us will change our management. We'll be worried that actually that isn't likely to be an effective treatment, and we're going to change our treatment course. And inevitably, if you're looking at an E. coli, what you're going to change it to, you're going to be pushing it to a higher tier antibiotic, a fluoroquinolone, one of these highest priority critically important antibiotics. And I worry that that's going to be the result of this implementation of the breakpoints. So we've got a study that we're looking for any animal that's got a positive bile culture for Enterobacterales. And we want to observe how they get on. Doesn't matter what you do, how you treat them. We're just going to try and build that picture and see which antibiotics are most effective. Can we compare different antibiotics? Because everyone has their own doses, their own durations and things. And we're not able to, this is a purely observational trial. We're not imposing any treatment adaptations. We're just interested to see, can we confidently continue to recommend amoxiclav for those types of infections? Can we provide real in vivo evidence of efficacy and doing that? And we've got some brilliant collaborators from America, from various universities in the States, and they have a tendency to use more fluoroquinolones. So I need the UK audience to get involved in this, and hopefully they're following Protect, hopefully they're using amoxiclav and things like that. And I want to see, are we doing a disservice to these animals? Are we actually letting them down with our antibiotic choice? And should we make a different choice to improve patient outcomes? Or can we continue to use this antibiotic and reduce our reliance on fluoroquinolones?
That sounds
So
really, really cool. So then tell me, are you actively seeking cases? And if so, how do people tell you?
email is the best way, and I can get them registered. I've asked lots of the veterinary diagnostic laboratories to communicate when they get Enterobacterales positive bile sample to just flag that to the clinician so that they will send me an email and I can log them into the system. All I want to do is recruit prospectively. So if you get an E. coli on your bile sample,
Yeah.
send me an email and I'll get you. We need to get the owner informed. We can't collect data about their pets without their consent. But it's straightforward. It's a purely observational trial.
Yeah.
So hopefully people will be willing to take part. I promise it takes a maximum of a few extra minutes to put this data in. We
Yeah.
do this all collaboratively. We're going to actually have some evidence to hang our hat on rather than just, well, making it up as we go along, which has
Yeah.
been what we've got so
Exactly.
far.
Yeah. Yeah. I will, with your permission, then I will include your email address in the notes of the
Please
podcast.
do. Yep. Yep. Absolutely.
Excellent. Okay. Fergus, it's been an absolute pleasure to host you. Thank you very much. As always, the aim of VetLit is to make veterinary literature not just more accessible, but actually accessed. And I hope we've managed that in some small way in this episode. If you found this useful, a quick star rating wherever you listen really helps these conversations reach more vets who might benefit from them. You'll almost certainly find something that interests you on the vetlit.org site, so do have a browse and check back here, there, or via the email updates for more. But for now, have a great day. It's goodbye from Fergus.
Bye.
And bye from me. Bye for now.